EMS CQI, that's what we are all about. Hello, everyone. Hope you're having a great day. He's Paul Gerard. I'm Kevin Kelly. We are Gerard and Associates. Check us out at gerardassociates.com. This is the GNA Way EMS CQI podcast. Thank you for tuning in. This is about EMS CQI, all things EMS CQI. Paul, how you doing?
I'm doing good. I'm rearing to go on this one. This is another topic that's near and dear to my heart.
Mine too. Yeah, it's a great topic. And today we're talking about PIPRs, and this is what we colloquially, whatever that, how to pronounce that, is known as paramedic-induced patient referrals, and the risks, the toxic environment, all the world's a stage, the whole 9 yards, the parade of horribles of PIPRs, and what they can do to get us on the front page of the newspaper.
Right. Just for the record, it's provider-induced patient refusals, not referrals. The problem is the paramedics are not referring the patient. You said referrals by accident. So they're not. So they're not referring the patient to the ER. Yeah. You got to stop the crack before showtime there, buddy. Get you a little too wired. So this is about paramedics behaving badly, right? So this is, and EMTs too. We say paramedics, but EMTs, paramedics, doesn't matter what cert level you are, doesn't matter if you're a supervisor or whatever you are. When providers get to the scene of a call and they actively try to elicit a refusal from the patient, that's a bad thing. It's always a bad thing. Shouldn't be done, right? Under no circumstances that I can think of should a provider be actively talking the patient out of going to the hospital. And we've seen cases of this, right, Kevin? The case in Phoenix?
Yeah, it was Phoenix Fire Department. It was actually a 2021 case, but is the risk of doorbell camera. It lives in perpetuity. Yeah. So now 2024, this thing's on the news, and once again, our brothers and sisters in paramedicine before the world stage not looking very good. They had a situation where they allegedly, although it's on camera, were dissuading a patient who ended up having pneumonia from being transported to the hospital. And the basis of that is that it's a rather expensive ambulance ride. It was a $1,500 ambulance bill. And putting that stream of thought, as we say, thinking drives behavior into that patient's head. And now you have a situation where you have presumably, and this is presumably without a thorough patient assessment, you have now this situation where somebody who needs to be moving toward a higher level of patient care with appropriately certified licensed caregivers is not.
Right. And it's you're basically abdicating your responsibilities to take the best care of the patient that you possibly can. So it happens. It's always happened. It's happened since we've been in the EMS for over 40 years, and it's happened all along the way. But it seems like nowadays it's happening a lot, much more frequently, and the patients are much more egregious in terms of their obvious need for medical transportation and care. And we're seeing these every day in the news. I'm sure folks listening to this will agree that they're seeing it all over the news where providers are doing this. So, as opposed to a standard refusal, which a patient has a right to refuse, any patient has a right to refuse, really, as long as they meet the competency requirements and such. But the issue here is that the patients seem to be trying to convince the providers that they should go, and the providers are making statements, and they can be they can be oblique, overt. It can be any variety of manner in which providers attempt to make statements. So as a CQI officer, you need to be on the lookout for it. You need to read between the lines, right? So this is where it's important that you use your experience as a field provider yourself to read between the lines of the run report to see what people are saying, to see if perhaps the providers tried to elicit the refusal. And sometimes there's language and terminology in the run report that we see. Sometimes they blatantly say, advise patient that the hospital is very busy tonight and that they would probably have a lengthy wait. Even if you said that to be good customer service to the patient, so they're well informed, it comes across as looking like you don't want to take them. So, providers just shouldn't be doing that sort of stuff. It goes against the grains of what we're supposed to be about.
So on a bring it to a higher level, bring it to an academic level, I guess. Steve Covey, 7 Habits, a highly effective paramedic level.
Covey wrote a paramedic book?
Well, we're writing the book based on Covey, but I'm thinking begin with the end in mind. First, seek to understand, then be understood. So, I guess my question to you, as the CQI guru, is why do we do it? Why do we take those risks? Why do we put the patient at risk? Why do we, as paramedics, put our reputations at risk? Even now, more than ever, knowing odds are we're going to end up on somebody's ring camera video, surveillance video. Right. The iPhones, the iPads, all of that. So why do we do it, Paul?
Yeah, see, that's a good question. The way we do CQI is that we're always trying to get to the root cause. So when we have discussions with providers, we talk not just about what you did and what you should do, but we're constantly trying to figure out through discussion with the provider, why did you do it that way? So that's why you and I have these discussions as to why providers do the things they do, is because we get a variety of answers on any of these topics that we talk about. And, we're pretty successful at getting people, winning over their trust and their respect to the point where they can speak fairly honestly with us, as opposed to trying to bullshit their way through the CQI process. And if they can be honest with you, then you can get to the root cause of what's really going on. So that's a long-winded answer to give background, but there's really kind of, in my mind, two categories: the intentional and the unintentional. So the intentional is where the provider is just being lazy, just doesn't want to do his or her job for whatever reason, just lazy in general, or they've had 14 calls in a 24-hour shift and it's 3 a.m. now and they're exhausted. And it could be that the hospital legitimately is backed up and it's going to take forever for you to offload that patient at the hospital to get back to quarters. So sometimes it's laziness, sometimes it's exhaustion or something else. But the unintentional is where people, I think, are more trying to be of customer service with the patient, or trying to make what they feel is a prudent decision of what the patient should do to get the care they need. Not every patient, and again, this goes against the grains of our discussion, but not every patient needs a hospital that we see in the field. And lots of EMS agencies now are trying to come up with ways to divert patients to lesser resources, or other resources, I should say, to handle their social, emotional, needs, or whatever their low-level medical needs, to stop burdening ERs and EMS systems, for that matter, right? So pull it out of the emergent response and put it into the non-emergent response category. So there's a lot of that going on. And in some cases, providers are inadvertently trying to help the patient by saying, you don't really need an ER. It's going to cost you a lot of money. The ambulance ride is going to cost a lot of money, when you can go to a walk-in clinic, perhaps, or you can go to your doctor's office, perhaps. So even if they're well-intentioned and they try to make that stuff to inform the patient so the patient can make an informed decision, that is going to look very much like a provider-induced refusal, especially if something goes wrong. So in most most jurisdictions, there is not a protocol for that sort of diversion of patient to other resources. So you either have to follow your policy, if you have one of those policies, very, very closely, or you need to transport the patient, make every effort to transport the patient, as opposed to trying to advise them not to go to the ER.
You and I, at one point in our careers, were chiefs of paramedic services, and part of our responsibility was to put together a budget, have that budget approved by the E-board.
Right.
What's wrong with having discussions with patients about the cost of our expert services? We're not ambulance drivers, right?
Yeah,
I mean, that notion's long gone.
Right.
We bring a highly sophisticated ambulance emergency service, emergency department that we can set up in patients' living room, and that's not cheap. We certainly deserve to be paid for our services. What's wrong with having a conversation with patients about the cost versus benefit of alternative modes of caring for your loved one?
Yeah, great question. That's the $1 million philosophical EMS question that's going on right now across the country, right? With these programs where, we used to call them expanded scope and, primary care paramedics. There's all different terms for what people are trying to do. But, to get patients out of that 911 setting, it's more costly. It's more time consuming. ERs are backed up, which means patient care is getting delayed. So I think there is a place for that dialogue to occur. But that has to happen at the administrative level and much higher levels, and then have it implemented legitimately before you start to do that. And what we're talking about here is your garden variety 911 services, where you call, we haul, and those systems traditionally have been set up with whoever calls gets a ride to the hospital, and we should not be refusing a ride to the hospital because the patients need to be diagnosed for what's really going on, which can't be done effectively in the field in most cases. So there's a lot of risk there. So providers should provide transport capabilities. In fact, on a lot of EMS systems, the statewide treatment or the regional protocols dictate that you must transport all calls for all 911 calls unless you get that legal, legit refusal. So that's a restrictive type of system that most EMS systems were built upon and still exists to this day with that sort of mentality. So within those systems, you don't have the flexibility to have those discussions if you're trying to attempt, and it comes down to intent. Are you trying to attempt to distract that patient from being transported, or are you trying to inform them of all of their options so they can make a prudent decision? Very fine line there. And you're the lawyer. You should be telling me where that line is and why it's so difficult for providers in the field to try to skirt that line. So give me a legal.
Yeah, I'm a criminal defense lawyer. You need to get that information from Doug Wolfberg and Steve Worth and those guys. There's a whole body of people that can answer those questions.
Yeah.
But to your point, when you reimburse by Medicare, there's a process where if the level of care or whatever you're requiring doesn't meet the Medicare guidelines, that the patient's on the hook for that. And there's a form, and you make them aware that you could be on the hook for the ambulance bill for that.
Well, in the rest of the healthcare system, those discussions are required to be had between the provider and the patient, not just cost, but medically, what's in your best interest. So if you go to a local community hospital and they don't have a certain test or procedure ability, you're required to advise the patient that they should, be transported to another facility because they can provide those tests. Here's what it's going to cost. You're going to need to go by ambulance. They're supposed to educate the patient about all their options, all the options available to them, so that they can decide what they want to have done. And, EMS is a little bit different because we've got these historic, traditional, nope, we need to transport you just because. So we're actually evolving this conversation from provider-induced refusals and your provider shouldn't be getting them and stop it, to a EMS should have a system by which it can inform patients of both the costs as well as the medical implications. The issue I see is, to kind of answer your question more directly, is if providers are there on scene and they're saying to the patient, it's going to cost you $1,500 to go to the hospital, that alone can be a distractor, right? That alone can make the patient go, whoa, are you kidding me? No way. Now, it may not cost $1,500 to the patient, right? If they've got insurance, depending on what type of insurance they have, there's all sorts of weirdness that can happen from a billing perspective that will ultimately determine if you owe a bill and how much of that bill you will owe. So it's a little misleading to just say to the patient, it's going to cost you $1,500. It might not cost them anything if they've got proper coverages and, it's the right set of circumstances. So because that's better left to billing people to determine what that is, you really probably shouldn't have your paramedics, having that discussion, I don't think, in the field. Or if it should really be generalized that, it's expensive to take an ambulance ride sometimes. We don't want you stuck with a bill. But again, you're getting into that inducement part where you're unintentionally perhaps, but you're laying the groundwork for the patient to think that you're advising them that perhaps they don't need to go, or it's going to be too expensive to go, or they don't need to go clinically. And that's just an area that's fraught with liability.
Yeah, I don't like the whole concept of talking a patient out of going to the hospital with that, that being an action verb. If the patient, based on a question answer with the paramedic and the EMS provider, and I believe the agencies have to address this issue, right? People turn on the news. People aren't getting richer. They're getting poorer. Mm-hmm. The issue of medical debt is not getting worse. It's getting better. It's getting much worse. So I think that these are logical questions that can come up during the construct of a patient care scenario. And I think it's incumbent upon the agencies to teach their highly educated, highly sophisticated paramedics some words on and some script on how to handle that particular situation. Mm-hmm. And then the other thing too, Paul, is before you even get to that, Are you assessing the patient? Where were you in this? Is it right out of the starting gate? Is it, it used to be airway, breathing, circulation. Then they added scene safety, airway, breathing, circulation. And then it was what? Disability and exposure. And they now adding before scene safety? Are they adding like a balance sheet discussion on insurance and financial management?
Yeah. Well, again, that's going to take a lot of time to get all that clarified for the patient to make a prudent decision, right? So there's
and have a sheet, have some kind of sheet where you hand the patient, ma'am. Your patient's, your mother's not breathing; she's blue. We're about to start CPR. Here's all the information you need to know. While you're assessing how much it's going to cost, we're going to package up and start what we need to do.
Yeah, I disagree with that. I do not believe that providers should be discussing the financial implications. It's too complicated, Kevin. There isn't a sheet that's going to say, the first question out of their mouth is going to be, okay, how much is it going to cost, right? And they don't know. Providers in the field do not know that patients are responsible for copays, deductibles, or maybe the bill in totality. So that could be a $2,000 bill, or it could be a $25 copay. Who the hell knows? Providers are not trained in all that, and it depends on what insurance. So what are we going to do? We're going to ask the patient if they got Blue Cross versus Medicaid, and then call Blue Cross and say, "Is this a covered service?" And how much would it be? How much would it be for grandma to get transported in her cardiac arrest situation?
You have the same sheet that you give them for Medicare that explains the fact that if you don't meet guidelines,
why they're reading this? The family members are reading this. And they're asking you questions. I don't understand all this because this is beyond me. All these questions about billing and all sort of shit. Who's working on the patient?
We are.
No, we're not. We're answering questions about billing. If you hand them a sheet and the family member saying you're doing CPR, and you hand a sheet to the family member, and they're tapping you on the shoulder saying, Kevin, I don't understand. Does this mean we're responsible? How are you gonna do that in an active call where you guys are really busy as it is trying to provide good patient care?
So you're saying that with an officer, an engine company with 4 people, and another officer, an ambulance with 2 people on it, and somebody can't take the time to say, "Ma'am, we're working on your it's really important. Here's the information that you need to understand."
First of all, that's not every system in the country. Most systems, you got 2 guys. There might be 2 basic EMTs, and you're asking them to explain the financial implications of whether the patient should go to the hospital or not, on scene in the middle of an emergent call where the patient could be deathly ill. We have problems getting providers to provide the right care in a timely fashion without that distraction. How are we going to now add billing? We want you to do billing. When I started in EMS in 1979, my first ambulance job was for a little private company in Rhode Island. And we used to have credit card charge things. So we would go to people's houses and ask them for their credit card to charge the ambulance job. Most of the calls were non-emergent, but there were some, I'll call them semi-emergent, because the local fire departments would call us to do a transport if they didn't want to do the transport themselves. And some of these patients were kind of sick, and they shouldn't, by today's standard, they would never be allowed to be, turfed down to a transfer truck. And so we would go and we would have these conversations, and that's exactly what would happen. As soon as we walk in, the management told us that we had to advise the patient of their responsibility to pay. And the first 15 minutes of the call, the patients were like, wait a minute. What's this going to cost? What do I need to do? Hang on a second. I'm going to call my insurer myself. I disagree with that. I think it's covered. You're telling me it's not covered? How do I know if it's covered? And we get into all this bullshit, and we weren't taking care of people. So in most systems, you have 2 providers. You don't have an engine company, officers, a third, person to help you. And even if you do, in the middle of a cardiac arrest, all those folks are busy, right? All those people are carrying, 4 people are carrying that patient down a flight of stairs, in addition to the providers getting set up in the ambulance. There's just so much to be done. It just doesn't make sense to me to have that. Now, I'm not saying that patients shouldn't know their options. They should, but there's got to be a better way to do that. And the reason you don't see it in 911, in my opinion, is it's too cumbersome and it's going to distract from patient care activities. In a hospital, you have a billing person and that an intake person, right, who does the registrations. So you bring the patient in, the medical people see that patient in the ER right away, and they get to work on the patient. Somebody else comes along and says, hey, family members, can I pull you aside and talk while they're working on the patient? When you have 2 people on a call, I just don't see that as, even if you have 4 people on a call, I don't see that as being necessarily very efficient and effective. In most cases, as I said, like I said, for what we're doing in CQI, the vast majority of the problems we have is getting people to do things in a timely manner. If it's taking 18 minutes to get your aspirin, and now you got to talk about this other stuff, it's going to be 45 minutes before you get your aspirin. So I disagree with that. I think that even though the patient should have the right to understand, perhaps that's something that they should be advised to call their insurer well before there's an emergent 911 call and see what kind of coverages they have. Perhaps that's something that they need to do. But I don't see it being the provider's responsibility to try to get billing information so that we can try to verify how much they cover, so we can advise them appropriately what this is likely to cost them before we start getting them on their way to the hospital.
All right, so it sounds like you're not keen on paramedics having discussions
Nope.
about finance. Is that because of this Bryant University finance degree and all of that? You want to own the domain of that, or is it? So you can't have a conversation about finance, and you can't talk them out of going to the hospital because of money. How do you deal with it? You just take care of the patient and say, we can't talk about money. Let's go.
No, yeah, I think in essence, yeah, because they can't talk intelligently about money. You tell me what paramedic. I'm going to ask you, Kevin. You're having chest pain, and I show up to your house and I say, "Hey, Kevin, this might cost you $1,500. You're an EMS. You were a manager. You were involved in billing stuff. Do you know how much it might end up costing you when you get transported by a 911 emergency vehicle?"
Yeah, zero. It's not going to cost me anything.
But you know that because you're informed.
No, I know that because I'm a DNR. I mean, I'm not having anything done.
Well, then why'd you call the ambulance?
First of all, I'm not calling the ambulance. That's all right. So we're beyond these. This isn't about me. But to your point, right? We started off with paramedics. We dissuade paramedics from talking people out of going to the hospital, whether it's for financial reasons, whether or not they think they have the sniffles versus pneumonia, that our job when we show up on scene and our mission is to provide some type of patient care. And that includes the transportation to the closest appropriate medical facility.
Yeah, that's your protocol. Yeah.
And as far as the whole finance, which I think is a very valid discussion. Yes, you have to deal with that proactively and ahead of time. And I think that having the ambulance services do a community outreach about the cost of the actual cost of how much money you need to adequately fund EMS is a very healthy proactive discussion to avoid having to have those conversations.
Yeah.
How much is this going to cost me? Because Paul, the other side of this thing, the other side of the coin is that, it's all great. We're taking care of patients and no one's talking about money. We're high-fiving and Aunt Betty's great. She's breathing again, blah, blah, blah. But then you get the ambulance bill and you think the insurance company takes care of the whole thing. And you got some kind of, whacked out copayment or deductible that costs you $1,000.
Yeah, those are all systemic issues that need to be fixed, no doubt about it. But they're not going to be fixed by the provider in the street at the point of patient contact. Right. So when the provider sits in front of the patient and says, "This is going to cost you $1,500, and oh, by the way, I think it's more sniffles than pneumonia," this is a recipe for a freaking disaster. In fact, it's on the front page of the newspapers all the time right now for that sort of activity. Yeah. So providers have got to stop doing it. So to get back to our original premise about the provider-induced refusals, the CQI officers have to monitor for this sort of thing. And when they discuss refusals with providers, they have to impress upon them that they cannot elicit a refusal from a patient. And what language can they use with the patient and what language can they not? Because you know as well as I do that providers will kind of slip this in with, non-threatening sounding phrases like, "Well, the ER is really busy right now, just so you know." Kind of thing. And it's because they don't want to do the transport, not because they feel that the patient is so minor that they don't need to be transported. But it's not our decision to make that determination, right? There's nothing in protocol that says assess the patient, and if you feel like it's bullshit, tell them they don't need to go. Get the refusal on them. There's no protocol that says that.
Yeah, that's true. And, and that's there are two things that I think the one percenters, the 1% EMSers are great at. And just crush it no matter what. Number one is mega code. I don't think that there's just anybody better than paramedics. Yeah. And then number two, getting out of work. in actually doing this, and the creativity that is put into talking to a patient that they don't need to go to the hospital at this point, or you can call us later. You know how to reach us.
Right.
We're at 911.
Yeah, that's right. Just call us. Yep.
A huge risk area. So a call to action. A call to action for our listeners. Number one, I'm going to say, this whole lawyer thing, as a criminal defense lawyer, and seeing how some of my defendants are, my clients are ending up on Ring camera video.
Right.
I'm going to suggest that if you're a CQI guy, and maybe you're already doing this, Paul, because you're a 1%er, but you got to review 100% of the patient refusals.
Yeah,
would you agree with that?
Oh, absolutely.
It's got to be reviewed, right?
Absolutely. And you got to have pretty strict requirement when reviewing those cases, right? So if the language is not clear, perfectly clear, you need to re-educate.
You bring them in and ask for additional information, clarify that, because we're not garbage in, garbage out, and things happen. So we want to get a hands on that. But what are you looking for as a CQI pro? And when you're reading these patient refusals, that the light bulb goes off that says, maybe I want to bring this person in. This is just not sounding like This is a patient.
Yep.
Versus a paramedic.
Yeah, good question. The very first thing our auditors look at is their on-scene time. If you're on scene for 6 minutes and you got a patient refusal, you did not do a good assessment, advise the patient properly, contact online medical control if you needed to before cutting them loose, all the steps that you should take.
All right. So if it took you longer to write the refusal than it did to assess the patient, that's a red flag.
Well, that's the problem, Kevin, is that the folks who cut out doing the transport also don't write very good refusals. So it won't take them longer to write that refusal. Oftentimes that refusal is 2 sentences long. Yeah. Patient didn't want to go. We came, we saw, we left. So,
the patient, right.
Yeah. So that's so that's number one. Number two is we look at the overall totality of the assessment. Was the assessment detailed? When you get to a refusal and they did a 12 lead on the guy, they checked the blood sugar. They spent 34 minutes on scene. They made statements like, we advised the patient. The patient didn't want to go. So we talked to the wife and advised her that she should help us convince the patient to go. And they're making all these extra steps and efforts in their verbiage of their documentation to show that they were making a lot of good faith efforts to try to convince the patient to go. Those things stand out. Conversely, if they don't do any of that stuff, they don't document any of that stuff, and they have a half-baked patient assessment to boot, then there's all sorts of red flags that jump out on that for reasons why the patient should potentially have gone and what you should have done. And the other is online medical control. So a lot of jurisdictions now have what they call high-risk refusals, which are patient refusals where the patient's really sick. Everybody knows that they should go to the hospital. I'm having chest pain and you're pale, diaphoretic, and clutching your chest. You really should go to the hospital. Right. For those high-risk refusals, you're required to call online medical control to try to get medical control involved, and perhaps they can convince the patient to go. And they'll also help you with the competency thing, right? They might say, hey, this guy's, shit-faced out of his mind. He's not capable of signing a refusal. Take him anyway. Take him against his will. Or get what we call here a mass of Section 12, or in Connecticut, they call it PIPR form. Different places call it different things, but it's some form of forcing the patient to go in some cases. So there's a variety of things. We look for the thoroughness and the totality of whether they've done everything that they should at their disposal. And we look at the language when they write the report. What types of things are they saying in the report that might be code for, well, we advise the patient of all their options. What options did you exactly advise them of? Did you advise them that their option is, you don't need to go, don't bother us again, unless you're dead? So there's quite a few things, but the time, the thoroughness of the assessment, and what steps they took specifically to try to convince the patient to go. And we coach people up to get that information in. A lot of times providers won't think to add that they actually advise the patient 4 different times, we really think you should go. That's important information as opposed to the generic, we advised them they should go and they said no, right? But if you advise them 4 times and we advised the daughter, who also then tried to intervene and convince the patient to go, and he told the daughter to go to hell. Yeah. Get that all into your story, because that's important, and it shows your intent. It shows that you tried your hardest to get them to go.
I'll add, be mindful of the competency and capacity of the person you're seeking the refusal from. Mm-hmm. We've had cases that you and I have worked on where the person didn't have the capacity to refuse to begin with, and that creates a panoply of problems. particularly with the Office of Emergency Medical Services.
Yeah.
And the other one I'll add is when you have these, and this was a potential blockbuster that got headed off at the pass, but this was going to trial. When you have these low-speed MVAs with high-risk pregnant females without any injuries who are, well, I'm not sure if I need to go to the hospital. What do you think, boys? And you're saying, well, you know, all your other kids were fine, right? You never had any, you've been in accidents before and nothing bad has ever happened, right? Yeah, you don't need to go to the hospital. Big problem. So be mindful of the level of acuity of the refuser, the capacity, the competency of the refuser, and err on the side of getting that patient to the hospital and avoiding the risk. Now, if the patient doesn't want to go and they are competent and you've checked the boxes, plugged up all the holes in the Swiss cheese in that risk management process, and you can comfortably, even with medical control, allow the patient not to go. Document the shit out of it, and that's okay. At least if you get it into a jam, you got a bunch of evidence to support that you did everything possible to coach that patient into being treated and transported.
Yeah, and we see refusals that are inappropriately obtained, even though the provider didn't necessarily try to get a provider-induced refusal, all the way through to provider-induced refusals. And all of those are also billable calls. Every agency we start with has some percentage of calls where that is going on some level. The vast majority. It's very rare that we start with an agency where that's not happening on some level.
Right.
And one of the things we do when we talk to new clients is we put together what's called our ROI calculator. You can find it on our website at GerardAssociates.com. And we pick we have a range when we start with clients of really good agencies that are really on top of their game. You might see a 5% inappropriate refusal rate versus all the way up to a 30% inappropriate refusal rate. And we actually can plug that into the calculator to determine how much money you're losing. And in most cases, it pays for your QI initiatives. So it's one of the areas of lost revenue that providers don't get because they don't pay a lot of attention. Even if they review refusals 100%, they oftentimes don't hold the providers to a high standard of verifying whether it was legitimate or not. So that also, everybody needs their cash flow to improve these days. And you're letting money leak out the door by inappropriate refusals, inappropriate BLS calls that should have been ALS, and a variety of other categories. So provider-induced refusals are not only terrible from a liability standpoint, you're losing a bunch of revenue from it as well. So get on top of it, understand your risk, understand your issues for your agency that you probably need to get on top of for that. And, if you're of the mindset, as perhaps you are, Kevin, of the mindset that there should have more to their discussion to be an informed discussion, then that's something that management and legal and a whole bunch of other people, medical direction, everybody needs to be involved with to come up with something that might fit the bill to do that. But don't just willy-nilly let your providers make that determination on their own.
There you go. Couldn't agree more. All right. If people want to learn more about the ROI calculator, how Gerard and Associates can help them reduce PIPRs, reduce risk, how do they reach out to you?
They can go to our website, GerardAssociates.com. All that information is there, as well as a contact form for us. Or you can email me at paul.gerard, that's GIRARD, at GerardAssociates.com.
All right. Well, listen, everyone, thanks so much for listening. We hope you picked up some tips on how to reduce the risks of PIPRs. We appreciate you tuning in, staying vigilant, being about EMS CQI. For Paul Gerard, I'm Kevin Kelly. Stay safe, stay in the fight, and Godspeed.
Bye, everybody.
On 5.